everybody. It looks as though we have the normal post in the middle of BAUS night audience. But thank you very much for coming to this session. We have some excellent speakers here today to talk about evidence to guidelines and how research can drive excellence in clinical care. Starting off with Jim Cato, looking at how research can be embedded into clinical practice. Sam McClinton, who's led a number of national trials and lessons learned from those. And Howard Kinniston, who will be talking about how trial design and assessment of evidence can be integrated with what we do. If we want to get started, Jim, could I ask you to take the lectern and start this morning's session? Just to say that we will keep questions right till the end, so do write them down or send them through on the app.
Thank you, Vincent. Thanks, everybody, for being here to listen, and thanks to John McGrath for inviting me to give this talk, even if you can't be here. Although I'm the invited speaker, I think it would be fraudulent to be here without involving Derek Rosario. And one of the lessons, I guess, from today is that you need a team approach, and it's working together that can generate a lot of success, and that's one of the luxuries we have in Sheffield of a critical mass. I think we all know there are various ways to improve patient care, and surely that's the business we're all in. The first one is the one that I think most of us use, which is the sort of evolution of your practice over the last few years. We all know that you can learn a lot from your experience, but there's a bias towards your outcomes from the last 2 weeks. We all remember our great disasters or our great successes, and that can give you a skewed practice. Also, it's very clinician dependent. If you're really absorbed, if you really have a good handle on your practice, then the outcomes are fairly reliable. If you dip in and out, then that's not the case. And it means you can develop your own patterns of care, which are not necessarily robust. We know in the NHS that commissioner-led care and network-led care is one of the ways that they try and improve services. The problem for us is that we're not necessarily part of those committees. They're not necessarily informed by decision makers, and there's a real lack of rigor and buy-in sometimes. Similarly, James will know the strengths and weaknesses of guidelines, decision-making by committee. Lots of the time, there is no evidence at all, and it often defaults to evidence-based medicine. But I want to talk about research trying to drive quality care and improving outcomes, because I think that's probably, certainly in our hands, has been a very dynamic and a very useful way of doing it. Firstly, I think we know NHS and research are embedded together. We know that research is vital to patient care, but functionally, they can work distinctly. Hospitals are worried about targets, efficiency, economics, training and recruitment to clinical trials often goes out the window. I'm dually employed by the university, and they similarly have their metrics they worry about: research income, teaching expenditure, research excellence, and those don't necessarily overlap with the clinical trials. And you can be a fantastic recruiter for a trial, but it gets you almost zero credit for your university. But I think there's another model, and that's where I'm going to talk today. One is where clinical practice and research feed off each other. So you have a problem, you have an outcome, and they become meshed together in many ways. And there are many other benefits which I hope to highlight as a consequence of this model. And I think it's been very successful over the years. So I thought I'd start by taking you through some of the cases, because I think it's easiest to explain what I mean. So we'll all be aware of the PROTECT study, which has just reported the 10-year outcomes. So if we look at Sheffield prior to PROTECT, and if we look across the UK, PROTECT was run in 9 centres, and at the start of PROTECT, in the run-up to that, I suspect most centres had different indications to radical prostatectomy. We know by comparing between centres that there were markedly different T3 rates, so that tells you that surgeons were selecting different patients for populations. There were markedly different patterns of lymphadenectomy that were going on, and active surveillance back historically as it was then was really, you made it up in the back of an envelope for yourself. But we weren't alone. The radiotherapists had completely different fractionations. Depending on whether you were trained at the Christie or down at the Marsden, you had a different practice. Whether you treated the nodes or not was different. And then the pathologists had different processing. They had whole mount, they had sectioning, they had loading, they had different cutting. We had different definitions of what a positive margin was around the country. And the reporting criteria, some of it was strict, some of it was a long verbal text that was difficult to work with. But the minute PROTECT started, what happened is there was a unified pattern. So suddenly we had predefined templates for lymphadenectomy. We had monitoring protocols that were embedded in the study. We had an audit of outcomes to start with in case selection. And that meant that in the NHS outside of PROTECT in Sheffield, all our pathways tended to mirror Protect. 6 months after Protect starting, most of us were doing the same templates, doing the same indications for lymphadenectomy, doing the same cases for radical prostatectomy, because the trial was driving that. And the same thing happened with radiotherapy. There was a predefined radiotherapy protocol, there was predefined use of ADT, and it standardized it. For pathology, likewise. If we look at prostate biopsy, for example, we had 6 different protocols in Sheffield. We had various people doing different numbers of cores, local anesthetic, rebiopsy or not. And it meant for the nurses that it was chaos. They never quite knew who was coming that day. They never quite knew what to set up. But within 2 months of Protect starting, we had a single biopsy protocol because the trial had mandated this, and therefore we just all absorbed it. So pretty much overnight, we unified that pathway. And I don't think that would have happened if a clinical manager or our medical director or our clinical director had said to us, you have to all do the same thing, because we all had intellectual reasons why we didn't want to do that. With pathology, again, it became a key part. So a national chain of pathologists from those 9 centers started working together. They came up with common processing protocols, common reporting standards, and before you know it, these are now embedded in the National Quality Assurance Programme for Pathologists. And so that working group has gone on to lead the UK's prostate pathology working group and is now embedded in their national standards. That enabled us to write work, and here's one of the papers we published, and you can see in red the number of pathologists that were contributing to one of our surgical studies through that ability, and managed to show some very interesting findings. I'm pleased to see some of the UCL, UCLH people in the audience today. So PROMISE is another example. So again, most of us know PROMISE in this room. Prior to PROMISE in Sheffield, we had a complete random use of MRIs. So we had different indications. Some were getting it before truss, some after truss. Some patients were avoiding truss. Some patients were having an MRI and a truss and then ignoring the findings. That was at our end. Once you went to the radiologist, there was 2 or 3 of them doing different protocols. They were reading it inconsistently. We started to lose faith in their reports because they weren't correlating necessarily with the pathology. And there was an element of self-training themselves as they learned. Once PROMISE started, or in the build-up to PROMISE, we had a unified pathway. Again, the NHS pretty much absorbed the MR indications as within PROMISE and that pathway. We rationalized variability. It enabled us to put a nurse in this pathway to try and speed up and unify it, because we had the comfort and the security of knowing that there was a trial environment around this that had been validated, and we had unified reporting. One of the main things is we had radiologists who all became unified. They had training with Claire Allen. They had double control for reporting for quite a few cases. Suddenly we were using uniform MR sequences. And as a consequence, as clinicians, we found the service became far more robust and far more reliable. The same has happened with HIFU. So we're part of PART, which is a feasibility study of radical prostatectomy against HIFU. If we go back before PART in Sheffield, we were a big surgical unit. We didn't really have any HIFU service at all. We had a small number of patients who we would send to other centres. We had been part of TUCAD, which was a photothermal focal therapy trial, and that had been quite easy to recruit to. But most of us were unclear about the benefits of focal therapy. And I was a skeptic of focal therapy myself. But in getting part of PART, we then actually managed to learn and become reassured and work forward with it. So we understood what made a good candidate for focal therapy, because we started to see within PART those that were suitable, those that weren't. We changed our pathway, so we had another trust to actually image the prostate. And we introduced HIFU in a much more quality-controlled fashion. We also had some of the costs covered as part of the study. So for my trust, it meant that we had a subsidized setup for HIFU. And that meant that we had confidence to redesign our clinical pathways. So historically, you'd have chaos at the front end. One letter saying man with a raised PSA, 6 different clinics, almost random outcomes depending on those clinics, almost random outcomes after those clinics. We had very little idea where our patients were, what numbers there were. And I'm not saying all of this is due to research, but it was the research that gave us the critical drive to sort our pathways out, because we wanted to pump prime for PROMISE and PART. We wanted to keep our patients at equipoise so that we could then get them into some difficult to recruit randomized trials. And that meant we could now embed a nurse in that pathway up front, and that's what we now have. So the first thing that happens, you have a PSA, you have one of the nurses who turns out to have been one of the old Protect nurses, so extremely experienced, and they counsel about PROMISE and other studies, and we are recruiting very well from that point of view. So whether that be vaccination in Vance or any other study. If we take bladder cancer, we had the same thing. So here was our hematuria pathway, 10 consultants, 5 SPRs, 2 staff grades, 3 SHOs. You can imagine what was happening after that. Most commonly, the outcome was a diagram of the bladder with TCC written in it, nothing else, and they'd gone on a waiting list. But when we started to open trials, that was no longer enough. So we've been part of a recruiting biobank called IMUC, where we wanted to know the size of the tumor. We were recruiting patients, taking them to theatre, doing all the hard work, and then there'd be a tiny tumor in the bladder that we couldn't get anything from. So we wanted to know the size. We wanted to know about patient risk factors. So we asked our colleagues to start documenting smoking and occupational history. Caliber, we wanted to know the risk score of those tumors because we wanted to have an idea whether they'd be suitable for caliber and had they imaged the upper tracts. Many of these caliber patients, which is chemoresection versus TURBT in low-risk disease, many of them have been floating around the system for years and haven't had any upper tract imaging. And we're about to open Bladder Path, which is a randomized trial of immediate radical surgery or radical treatment versus TURBT for likely invasive cancers. And all of these required us to say to our colleagues, my colleagues, you've got to think about the cancer. Don't just say TCC. Is it solid? Is it papillary? How big is it? Do you think a registrar can do it? Do you think a consultant needs to be there? Have you done the imaging? Have you looked at the CT scan? Are you sure everything's done? And that's meant that we've got faster treatment. We have less operating room wastage because we are more careful about the cases we put on. And as a consequence, we get better staging, better pathway engagement. And so that actually has improved it. And again, we are now on the pathway to nurse-led driven care. And again, many of you are doing this. I'm not claiming this is anything outside the box, but it was the research that gave us the confidence and gave us the drive and gave us the resources to do this. And so we're now embedding nurses up front. And again, for studies like BRAVO or for Bladder Path, it's vital you keep patients at equipoise. So it's vital that you keep people in an environment where they are getting the right information. So that was about research improving NHS care, but it is circular, and it goes the other way. So if I look at BRAVO, which is one of the studies I've been involved with and running, this is a difficult study. It may not be possible across a number of centres. We're looking to randomise radical cystectomy against BCG. And it was part of the NHS that gave us trial design. So we had a number of working groups with NHS consultants, some of whom were in the room. We had teams where we had DGH consultants, teaching hospital consultants. We had people from outside the UK, Scandinavians from the USA. And between us, we came up with a pathway that we felt comfortable with. And in doing so, we kind of uniformed. So in Sheffield, I realized that we were doing far more rigid cystoscopies than most people were doing elsewhere. Elsewhere, we realized that a lot of people weren't looking at the upper tracts as often as possible, and we were doing slightly hit and miss definitions of surveillance. And so in doing that, again, across the region which includes Newcastle, we've unified a lot of the BCG pathways, we've unified a lot of the radical cystectomy indications. The same is true of IROC. So IROC is a study myself and John Kelly are currently running, which is robotic cystectomy versus open radical cystectomy. The robotic component has to be intracorporeal. You have to have ERAS on the pathway, you have to have unified care. And again, it's difficult, but it's enabled myself and John, so UCH, Sheffield Teaching Hospitals, big units, big heavy NHS units where targets are driven through all the time. It's enabled us to unify care, to think about our pathways, to get ERAS embedded in it. And actually, at the end of this, the question may not be which is better, it'll be we'll have moved on. But in doing so, we've unified a huge number of patients on that pathway, and we'll have moved the needle forward. There are other resources. So James and Dow led MAPS. This was fantastic for us. We had a nurse that recruited to MAPS. She got personalized training in pelvic floor exercises, and she sees a lot of our radical prostatectomies afterwards in-house without requiring physiotherapy. Nearly all of our information leaflets are heavily based on the clinical information sheets that came to us. BRAVO especially, we have patients who are only in BRAVO because they like the information leaflets as part of it. PART, again, patients really love the detailed information that was put into there. And a lot of these information sheets are not particularly well written outside of clinical trials. For our patients, we got HIFU set up in PART. We got a lot of support for that financially, free quality control within PROMISE, a lot of training for our staff. For IROC, we've got subsidised free robotic consumables, again, keeps the cost down for the NHS. And then there are other departmental gains. So for my colleagues, they get research time in their job plan. So even if they're not an academic, if it's like Jake Patterson who's recruiting to some of Sam Stone's studies, he gets research time embedded into his job plan. We get income through portfolio funding, which then feeds back into the department. We've been able to have NIHR-funded PAs for people to do clinical trials, study leave, and it makes you an attractive unit. So it means that people will want to come to your unit. In our junior staff, we've got clinical fellows and clinical lecturers who are extra to the on-call rota, so it's a solution to try and make the on-call rotas work. And for our nursing staff, and this has been one of our greatest gains, it's really brought them on. We have a very, in the NHS and particularly in Sheffield, we have a very steep pyramid to the top of the curve for our nurses. It's very hard to progress because the people at the top have been there for a long time. And this is an outlet for keen staff who want to progress, who otherwise would be leaving urology. It's an outlet for them to develop their skills, to get into research. And for our patients, they get better information, they get more time, they get more support because there are more people around. There are suddenly research nurses that come out of nowhere that take them off in the middle of a busy clinic, which makes my life easier. And our department as well. So we're now an academic department in our trust. We're one of 14. We get some money from our trust to try and raise money for patients coming in. We get moved to integrate hybrid nurses. So a lot of our clinical pathways will now have a nurse who's partly research funded at one of the key points, whether that be hematuria, whether that be PSA, and we're aiming for a LUTS thing. And it means we can recruit to a lot of studies across the board. And that means that within our trust, we're a small directorate, but we're hitting way above our targets and doing very well from our trust point of view. So financially, it's paying off for the trust, and for us, it's making our department more interesting and more dynamic. A lot of it's been clinical trials driving improved care pathways. I think many people do that anyway, but it was really the inertia that the trials gave us. Thank you very much.
Thank you, Jim. And you stuck to time, almost. Now, we've got great pleasure to introduce Sam McClinton, Professor of Urology in Aberdeen, who's led a number of the STONE trials. Sam?
Thank you, James. Good morning, everyone. I'm going to talk to you about STONEs and the lessons that we've learned in urology about research. I'd start by saying that none of this is possible without a lot of people within the section putting a lot of time and effort into setting these trials up. And it has been an object lesson for me in teamwork. So this is all about team. So within the section, what did we do differently from other sections? Well, I think very early on, we had a lot of interest in audit. And then we had a lot of discussion about what was the difference between audit and research. So we established a research and audit subcommittee within the section, and we also established a patient advisory group who would give patient input and views on the research that was needed. And we set up, through myself and James, links with the clinical trials unit. And I think those three things led us to look at what were the clinically important studies that, as endourologists, we thought we should be doing. And we then got clinical urologists to write the protocols for these studies. We started with a protocol for what later became tissue, which was a protocol comparing lithotripsy with ureteroscopy. We then got that adjusted by the clinical trial specialists who are great at taking what seems like a good idea, tearing it apart, and then putting it back together again in a format that actually will get some funding. The clinical trials unit bring a huge amount of experience. They bring a ability to take what we think are good ideas and actually tell you what's clinically possible and research possible. And they usually have a track record, and when you're looking for funding, you need a track record. So back 10 years ago now, we looked at what were the things we wanted to do research on. First was, how do we treat ureteric stones that need intervention, and in what sequence? How best to treat those lower pole stones on which there's very little evidence, and was medical expulsive therapy actually effective? The first study we actually put into the HTA was number 1 on that list. And initially, they turned it down. But a year later, they decided it would become important, so they did fund it eventually. But what came first was a call for a study looking at the effectiveness of medical explosive therapy. So we put a bid in through the section. The reason for the study was that alpha blockers seemed to be effective at helping ureteric stones pass. There was a Cochrane review which showed a reasonable outcome that it's a good thing to do. But when you looked at the data, the majority of studies weren't good studies. They were small, single-center studies, and the methodological strength of the evidence was limited. The primary endpoints were also very poorly described. Not many used CT, and the bone stone expulsion time was usually self-reported. So we put in a bid for what became SUSPEND, which was a placebo-controlled trial, and we ran that across the UK, looking to recruit just over 1,000 patients. This was reported, and Rob Pickard, who's in the audience, wrote this up and reported it in the Lancet, and basically showed no difference between placebo and any of the supposedly active drugs. And the UK audience seemed to accept this, and many people stopped using tamsulosin. But the Americans hung on to this single box that showed that maybe it worked for those big lower ureteric stones. But we were quite clear. We didn't think that there was any evidence that this was a useful drug. Since then, there have been 2 other large multi-center studies, both of which have shown exactly the same as SUSPEND. And it's possible, and we'll see, it's like guidelines, as James is aware. We'll see whether the evidence actually changes people's practice in America now. At the latest AUA meeting, there was actually a statement from Steve Nakada, which was unusual, to say that medical explosive therapy is dead. So we'll see whether that actually happens, see where the evidence actually leads us. The second thing we wanted to look at then was comparing extracorporeal shockwave lithotripsy with ureteroscopic management. And at that time, a Cochrane review again had shown that lithotripsy probably gave you lower stone-free rates, but the complication rate was lower and the length of stay was lower. And the conclusion was that ureteroscopy probably achieves a higher stone-free rate, but at a cost. Current data would suggest that endourologists have switched quite considerably to ureteroscopy, and the rates of ureteroscopy are climbing and the rates of ASWL are dropping. But the evidence for that is not good. So the HTA, again, with some prompting, put out a call for a study to look at that. And tissue was the section of endourology's answer to that. And we have been recruiting to that over the last 4 to 5 years. It's basically all adults with ureteric stones who need intervention. We have 611 participants recruited, and we'll stop recruitment at the end of this month. Like most of these target recruitment figures that you see for studies, we did not reach the target that we had hoped to achieve, but we've achieved the kind of numbers that we needed to answer the question. So at the end of this month, we'll start to finish the data, and I would hope by next year's BAUS, we'll be able to provide you with some solid evidence as to which way you should treat these patients. Our last research priority was how to treat lower pole Riedl stones. Again, the current evidence was based on a Cochrane review. They ended up looking at 3 studies in the literature. 2 were comparing lithotripsy with PERC, and 1 comparing lithotripsy with flexible uteroscopy. The data from these is not good in terms of the numbers of patients involved, and the differences were not sufficient really to draw any strong conclusions. But this is the data that we've been using for the last 15, 20 years now to drive our practice. There was absolutely no evidence from any of these studies about patient-related outcomes, about quality of life, about the care pathway that would be best for patients, or about resource use. Again, the HCA put out a call really to look to see whether flexible ureteroscopy, which was a new technology, was a useful treatment for renal stones. We went back to them and said that that wasn't really the study they wanted to do, and we offered them PURE, which is a study comparing percutaneous surgery with flexible ureteroscopy with shockwave lithotripsy. And the hypothesis was that patients receiving flexible ureteroscopy as their first treatment option wasn't superior to outcomes in patients receiving either lithotripsy or PCNL. So it's a non-superiority treatment effect. We offered them 2 RCTs in one, so they have an RCT, one which compares flexible ureteroscopy with lithotripsy for smaller stones, and a second RCT comparing flexible ureteroscopy with percutaneous surgery. The study is now open. We have a primary outcome, which is patient-reported health status, so not stone-free rate. So this is a patient-reported outcome rather than a stone-free rate reported outcome. But the secondary outcome will be stone clearance and a number of other important secondary outcomes. We're going to analyze the 2 RCTs separately. We will subgroup and analyze based on the various things that seem to be important: stone center, the BMI of the patient, stone size and volume, skin to stone distance, and there's been some discussion at this meeting about whether or not skin to stone distance is as important as it seems to have been said to be in the past. Whether a flexible instrument is as good as, for example, a mini perc, and flexible and fixed against mobile lithotripters. We've currently got 25 recruiting centres spread across the UK and in Ireland. We hope to have at least double that number of recruiting centres by the end of the study. Projected recruitment rate is the same for both RCTs. We are recruiting to target for RCT1, but are slightly behind for RCT1, which is for the larger stones, which I think is to be expected since the number of larger stones is less than the number of smaller stones. We've found excellent support from the Clinical Research Network. We've had a lot of difficulties with the changes in the system for research, which took a lot of time to clear and make sure that all of our centres got up and running. But some places we've not been able to progress due to lack of research nurse support. And as Jim says, it's important for units that they utilize these research projects to drive their management to fund support for it, because it brings in income for their trusts. So what are the lessons from all of this? Well, you do need an active research and audit team. You need a group of people who will drive these studies. You need patient input to ensure that what you're doing is relevant. You can't do these studies without a clinical trial unit support. And I think for anybody who's starting out doing research projects, the first thing I would say to you is that you need a clinical trials unit to help support your drive. I think most importantly, you need clinical urologists and their teams. So we need people who are working in units to write the protocols, to recruit the patients, and to ensure a successful trial outcome. It's not dependent on the principal investigator It's not dependent on the clinical trials unit. It's people in the units who see patients and recruit them who drive these studies. I'd like to thank all of those people on the slide, particularly the members of the section who helped to drive these studies through, and all the other people who've helped support it. And a big thank you to all of you out there who are still recruiting, and keep doing so, please. Thank you.
Thank you very much, Sam, for an excellent run through the development of these really crucial trials. And now we have Howard Kynaston from Cardiff to talk about the relevance of trial design and assessment of evidence.
Thank you, Vincent. Ladies and gentlemen, thanks for the invitation. I'm going to summarize some presentations that were given at the academic section meeting earlier this year around clinical relevance in trial design and the assessment of evidence, and that was with Graham McLennan and John Graham. Graham's a statistician, and John Graham you will know as an oncologist based in Taunton who does a lot of work with NICE. So we're all familiar with this evidence-based pyramid, where we think that the quality of the evidence increases as we enroll in randomized controlled trials and the systematic review of those trials, where we do have a lot of expert opinion and editorials at the base of this pyramid. So if you look at some examples, this is an example of expert opinion not being quite correct in its assumption. So this is a book that sold a lot of copies in the States in the 40s, 50s, and 60s by a rather slightly eccentric pediatrician who believed that if infants were put to bed prone, then that would probably reduce their risk of sudden infant death syndrome. And this was a popular belief. But when this issue was examined in cohort studies, in case control studies in the 70s, 80s, early 90s, it was demonstrated that really infant sleeping position was associated with sudden infant death syndrome, in the prone position being a worse factor. And this led to recommendations and guidelines. So this is what happened in the States. So if you look at the green line, this is the increasing percentage of infants sleeping supine, and as that increased, the sudden infant death rate in the US fell. So that's an example of putting together cohort studies to drive guidelines and improve care. But I guess really we're quite interested more in randomized trials and the systematic review of those. So I'm going to go through some examples of these. So in terms of trial design, it's a really important concept to consider this sort of PICO formula, not just in trial design, but also in interpretation of trials. So we have a population, the intervention, comparator, and outcome, and the population is critically important. And there are three main types of intervention trials. There's the common superiority trial. This is a trial that we're most familiar with, sometimes known as an efficacy trial. So we're looking for a new treatment to be better. And then we've got an equivalence and a non-inferiority trial. And these trials are often considered very similar. But if you ask a statistician, is an equivalence trial the same as a non-inferiority, he'll usually say yes and no, because they can be, but often they aren't. So let's look at a superiority trial in urology. So this is a study we're going to talk about related to what is the best treatment for locally advanced prostate cancer. So just take a moment to think about the best treatment, because that is a term that we use frequently, but is a little bit ambiguous. So in the 1990s, when I was a registrar, the standard of care in the UK was hormone therapy alone. And in surveys of oncologists and urologists, the view was, mainly by urologists of course, that giving them radiotherapy was somewhat meddlesome and unkind. And this was based to some extent on Griff Fellow's study from Oxford, an MRC study demonstrating that hormone therapy alone or radiotherapy alone compared to the combination, there was no improvements or benefits in terms of overall survival at 6 or 7 years. But the trial was rather underpowered and failed to fully recruit. So there was still an unanswered question around the man with locally advanced prostate cancer, whether hormone therapy alone or combinations was the best treatment. So this was the origin of the Canadian MRC trial that we know as BAUS17, and this randomized men with locally advanced disease between hormone therapy alone or the combination of hormone therapy and radical radiotherapy. So going back to our PICO formula, the population were men with locally advanced disease but M0, so it's just a negative bone scan under the age of 80. The intervention was the combination treatment, the comparator hormone therapy alone, and the outcome overall survival. So in terms of surveys at the time of clinicians, I think urologists, oncologists were fairly equally divided between their view of which was the best treatment. About 43% thought hormone therapy alone, and 53% thought the combination was better. And I suspect this represents urologists and oncologists completing the questionnaires. But when asked what benefit in overall survival of adding radiotherapy to hormone therapy might be, around a third said 5%, 25% between 5 and 10%, and about a quarter thought the patients would be 5% worse. In answer to the question, how much better does radiotherapy need to be for it to be clinically useful or meaningful, it was quite a large ask, I think 15% in a solid tumour in the 90s. So that was a fairly exaggerated response. So this is the outcome of the trial, which was reported a couple of years ago now. So this is the BAUS17 trial demonstrating in terms of overall survival, the combination treatment in yellow, there was a superior overall survival at 10 years. Hazard ratio of 0.7, an absolute difference of 6% improvement by combination treatment. And this drives improvements in care and informs guidelines. If we look at that data another way around, then we've got the deaths from prostate cancer specific deaths over 10 years. In the combination arm, the death rate was essentially halved. And this had impact when viewed in that way. So this was the MRC website, 2015, adding radiotherapy to hormone therapy halves deaths from high-risk prostate cancer. So that's a good example of a superiority trial in urology. Now let's look at a non-inferiority trial. When might that be used? So this is often used when the gold standard intervention is known and readily used. But a new intervention may have some potential advantages. It may be less invasive, may have less side effects or be less expensive. It may be more widely available because it can be done in many more hospitals than a tertiary centre. And perhaps it doesn't prevent the gold standard treatment in the future being applied if it is required. But one important issue at the outset is to state the limits of inferiority that are acceptable. That's known as delta. So how much worse or less effective could a treatment be to make it similar but in terms of the primary endpoint, but has these other benefits? So this is a figure now showing the results of various scenarios in 8 studies. And if the 2 treatments in each of these trials were equivalent, then the median would be in the 0 line between new treatment better or new treatment worse. Delta in this slide is given here. So this is on acceptability of inferiority. And if we say, for example, this is 15% worse. So if you look at the first trial, trial A, then in trial A, we can say that the new treatment is better. It's significantly better because the mean and the confidence intervals are to the left of the 0 line. But these 3 trials, B, C, and D, show that the new treatment is not inferior because all the means are in the blue square, if you like, the blue color, and the confidence intervals do not touch this line of non-inferiority. In fact, trial D demonstrates that new treatment is actually statistically inferior, but because it does not reach this line of delta, which is predefined, it's a non-inferior new treatment. These three studies here show that the results are rather inconclusive because the confidence intervals now cross the line of inferiority, our predefined line, even though this trial shows the new treatment is statistically inferior. So the only trial which shows that the new treatment is statistically and clinically inferior is this trial at the bottom. So this is an important concept to define your level of inferiority before the trial starts. So here's an inferiority trial. So this is recruiting at the moment in the UK, and we're back to this term BEST. So what is the best treatment for male incontinence following prostate surgery? We've got the artificial urinary sphincter and a male sling. So our PICO formula for this trial, the master trial, men having surgery for incontinence after prostate surgery. The intervention is the male sling. The comparator is the artificial sphincter, and the outcome measure is urinary incontinence at 12 months. So we could say that, well, in terms of best treatment in a non-inferiority trial for this study, non-inferiority would mean that basically if the artificial sphincter cured 80% at 12 months, the male sling would be inferior if only 65% were cured at 12 months. It's non-inferior if over 65 are cured at 12 months. And this is how the trial is designed. So the male sling would be non-inferior, but it may actually be the best treatment if it's less invasive, less complications, less cost, and more widely available. So you can see how the design of the study leads to, if it is a truly non-inferior result, that may be viewed as the best treatment. There are some issues around non-inferiority trials. The margin of non-inferiority I mentioned, delta has to be predefined. What's acceptable to clinicians, what's acceptable to patients. Issues with assay sensitivity and protocol violations are particularly important in non-inferiority trials, and there is a tendency for what's known as bio-creep or device creep. And what that means is if we have the gold standard is A, for example, that could be orchidectomy for hormone treatment in prostate cancer, compared to B, which is a medical treatment and is found to be equivalent or non-inferior, and then we compare C to B and say that's equivalent, C to D, and that's non-inferior, but really we're not sure whether A is equal to D, so D may well be non-inferior to A. So this is a biological creep in terms of repeated trials in non-inferiority. So turning to now how organizations like NICE would view the review of evidence generated from trials, the National Guideline Alliance is a group of three alliances, and they commissioned by NICE to develop service guidance and clinical practice guidance for use in the NHS in the UK. It's based on evidence clinically and both in terms of effectiveness and cost effectiveness, even though we as clinicians often stop at the first step here. In terms of development of a clinical guideline, the topic of the guideline is often referred by the NHS in England, goes through a scoping exercise, development, consultation with stakeholders, particularly a final validation and then publication. And this can take usually around 2 years for a full guideline, somewhat shorter, 1 year for some, and updates can take around 6 months. So if we go back now to the question we looked at earlier, the superiority trial, this is one of the PICO formats from the prostate cancer guideline that was published in 2014. The population was men with prostate cancer, which was non-metastatic. The intervention was the combination treatment compared with either one of these alone, and the outcomes are here, overall survival, and a number of other important outcomes which men would feel was important for them and their carers. And this is the way that the evidence would be reviewed. So each study is assessed for bias using checklists. So these were all the studies that were included in that review. And you can see PRO7 was here. Green means it's good quality, and it had some red negative marks because of some of these checklists to do with blinding of outcome assessment, etc. The Griff Fellow study is in here. The SPGG7 study is in here. So you can see that none of these trials light up green in all aspects, and therefore there are potential problems with them. But once that's reviewed systematically, then the result of that could be that, in this example, it was that combination therapy is better than single modality treatment, but qualified by low to very low quality evidence, even though we may think that that was actually quite good. But combination therapy was associated with more and worse adverse events and quality of life, again graded as low to very low quality. But the recommendation that came out, so this was the sort of headline news in the summary, that these men should be offered treatments to offer men with intermediate and high-risk localized prostate cancer a combination of radical radiotherapy and hormone therapy rather than a single treatment alone. And in nice speak, many of you will know if it says offer, it means there's very good evidence that that should be the case. It would be unusual not to offer that combination to men in those populations. The other thing that NICE does once it's published a guideline has a very important role in driving the research agenda in the UK, and Sam picked up a little bit on this earlier. So it will prioritise research questions where there seem to be gaps in evidence. So if you look in 2010, sorry, it's a bit small, so this was a research gap which was related to the timing of birth in women with preeclampsia. So that was fast-tracked through as an issue to the HTA for funding via the NIHR and led to a grant of 1.7 million. So that's how NICE can have an impact in terms of generating the research agenda in the UK. So finally, just to cover the update of NICE guidelines, a clinical guideline usually is updated every 5 or 6 years. And during the life of a guideline, there are these things called a surveillance report. And this has been triggered in CG175, the prostate cancer guideline from 2014. This was triggered at the end of 2016, which means there will be an interim update because of new evidence in prostate cancer management and diagnosis. And that was mainly from 3 areas. So these will be reviewed in the very near future. They relate to chemotherapy and hormone-sensitive disease as a result of the Stampede trial, MRI prior to prostate biopsy as a result of the PROMISE trial and other trials, and radiotherapy fractionation as a result of the CHIP trial and other trials. And there may be a review of practice related around the results of the PROTECT trial, around risk stratification. So you can see how NICE is able to review things within the life of a guideline if good quality evidence becomes available within the life of that guideline, and this is ongoing currently. So I think that's all I was going to say this morning. Thank you.
Thank you very much, Howard. So we've had some excellent talks here. We've seen how research can change clinical practice and some trials which have addressed key clinical questions, and then how we can interpret and look at that research. We have time for some questions. Anyone from the audience would like to raise any questions to our expert panel here?
Can I start by
Jim.
asking a couple? Firstly, I mean, Sam, in the oncology world, we're envious of how successful you've been with stone studies, and I guess that is a great example of the section working with trials and the funders. When I start trial design, I often start with the situation you described where we have clinicians, we understand the pathways, we understand the problem. You take that to a trial team and they basically dismantle it, as you say, and they come back with something that doesn't resemble anything that's going to work. Have you got any ideas about that? Because I'm often faced with a thing that statistically will work, but clinically there's no buy-in from any of us. How do you manage that?
Yeah, I think you've got to ensure that the people at the clinical trials unit listen to your clinical point of view. And they often will come back and say, no, we wanted to do this, to do it differently. And I think you just got to be a bit strong and stroppy with them, and tell them that won't work and you won't get clinicians to do that. And there's a bit of compromise between the two places to arrive at a trial that will work.
And when do you think you need feasibilities before conducting a large study then? If you had that tension there, or you had a situation?
So I think if it's an HTA call, they'll often build that into the trial. But if you're doing it before that, then quite often a pilot study is very powerful to help you drive the clinical trials unit the way you want it to go.
Mike, over there.
Hi, Roger Kirby. When I was young, like you guys on the panel up there, it was more or less obligatory for all urology registrars, senior registrars to do research. Now it seems it's the exception. So my question to the panel is, how do we restore research as part of the training agenda of young urologists?
I'll start with that if I can. Well, Roger, you did a lot to inspire people, so I think inspiration is quite important. I think the only thing is that a lot of the research that people did was actually, it gave a very negative impact, gave you a negative feel. You were often looking at something that most people weren't really engaged with. The researchers themselves felt they were doing it for career progression alone. And a lot of it was wasted effort. And that got, I think particularly got surgical research a bad name in the medical field. And standing next to John Kelly, we're often up against, we're on grants against the physicians, and there's a sort of rubbishing of surgical research because of what's happened in the past. So I think it's down to inspiration, trial design, getting people from the bottom up to buy into high quality research, and then trying to embed that in units like John's or like in Aberdeen where you can centralise that, and therefore people become career academics rather than just a stepping stone to a consultant post.
Thanks, Vincent. The panel really highlighted some of the excellence that can be driven out of UK urology, and I think we see step-changing trial results coming through. But Sam also highlighted an issue where we have a lag in recruitment, so our predicted to our actual recruitment are very different. And if we compare ourselves to perhaps HemOnc or the MedOnc community, where they can really gear up and generate large numbers in trials, are we missing some further step where we need to have a different engagement, perhaps through BAUS, to allow us to come together as a network in its true sense to recruit to trials quickly?
Yeah, I mean, I think our big problem is that we still have a lot of clinician bias in terms of treatment, so that the buy-in to the studies is not what it should be. And I think we're also a little bit naive about how we go about recruitment. We probably don't drive our studies through nurse-led pathways rather than clinician-led pathways, because nurses are much better than clinicians at presenting data in a non-biased way. So I think there are lessons that we've learned from the Stone studies about how to improve recruitment.
I mean, I think Jim's example earlier is critical in terms of developing infrastructure in your own department. Because if you've got that infrastructure, taking on new trials becomes so much easier. And it becomes part of core business in the department. If you're fairly isolated and have little in the way of support, it is very difficult to start studies.
Anthony Timney, for the panel really, should we not take a lesson from ProTech, where when they were having difficulty recruiting, they went back and they basically taught the clinicians how to get to equipoise. So if you take Pure 2, and we're really struggling with that, and I suspect it's because our body language is wrong, even though we might say the right words, and I think we could be tutored. And the trial might, if you look at the range of recruitment, I think that's obvious.
I think we all agree with you. The problem is you can't go back to Protect. The funding streams, the 50 million that funded Protect no longer exists. The NIH have invested that into the clinical research network. So my trust has research funding, but it goes to the CRF on level O, and you have to book part of their time to come down and help. And Protect kept patients in a cushioned environment with plenty of nurses around to keep that equipoise. I think you just have to adapt how you do it. We're doing Bravo, which is a similar difficult randomization, and we've tried our best. We've had, across Yorkshire, we've had training days, we've had sessions where we've had mock consultations with patients. We've tried to emulate Protect, but it's been difficult because we don't have the cushioning of the nurses around. I think a lot of it comes back to us. I think we've got to look in the mirror. I think I say, do you think the trial's worth doing? Do you really want to know the answer? We all have an opinion, but I'm prepared to park that opinion for the greater good of answering that question. And I may think that this patient deserves X, but actually I may get that wrong. And we've got plenty of examples where what the clinician thought was the right option turned out to not be the best option for the patient. So I think a lot of it comes from us. If we truly believe in Pure, we should do our best to get that through, to the point of actually going against what our own intuition may be, because it's important to answer that question, and we'll never build forward. And if from above we're saying that to our team constantly, then you'll overcome the resistance. But it won't happen overnight. You'll have a nurse who has an opinion, you'll have to work on that, you'll have the theatre scheduler who has a problem with you doing something. But it has to come from us first, I think. What do you think, Sam?
I agree totally.
Any other questions? Well, in that case, thank you very much to the panel here. I would just comment that there was an interesting corollary to this, the academic section, where we had speakers from mainly DGHs actually, talking about the difficulties of doing research in their setup. And I suppose one of the things we have to think about is actually whether we can get more units to have the infrastructure to be able to start to contribute to these trials. Because I think what was striking is that a lot of the studies, perhaps not the stone ones, recruit in the same places because they have the capacity to deliver that. But maybe that's a topic for a more integrated discussion elsewhere. Thank you very much again to the panel and to all of you for attending today.